Good morning, one and all. So this is the first session and the first day of Drishti 2024. And so far from the experience we've had with Drishti, I think it's going to be an excellent and awesome experience. So without any further ado, let's start off the session. And I'd like to first welcome the speakers on stage, Dr. Aditya Jyoti, Dr. Leena Varghese, Dr. Jacob Koshi, and Dr. Mohan Rajan. Sir is not here yet. When he comes, he'll join us. We'd also like Dr. Philip Kuruvilla to join us as an expert panelist. Please come on stage. So our topic is on MSICS and the challenges that commonly we face and how to overcome these challenges consistently. Without much wasting time, let us start off with the first presentation, which will be by Dr. Aditya, scleral tunnel related challenges.
Good morning, everybody. Such an honor to be the first speaker of the Drishti meeting. Thank you, KSOS Drishti Organizing Committee, Dr. Ashish Kuruvilla, for giving me this opportunity. So right away, we'll start with the topic. I'll be talking upon the scleral tunnel related challenges in SICS. Why scleral tunnel is so important? Because it gives a more oppositional surface and improves the wound healing. It can reduce the surgically induced astigmatism. Then it creates a three-valve mechanism which makes the tunnel self-sealing, and hence it becomes a sutureless incision. This is how the cross-sectional anatomy would appear. How the good tunnel should be. It should have a square geometry so that it gets a good strength. The external incision should be a smaller one than the internal larger incision. And the side pockets or the scleral pockets should accommodate the nucleus when it comes out of the anterior chamber. For a beginner, as such, when he is doing a superior incision, taking a bridal suture is very important so that he gets a good surgical exposure, followed by an adequate limbal peritomy. Do remember to clear the episcleral tissue also, otherwise the incision will be very ragged or irregular. And then do a minimum cautery. Do not over cauterize, otherwise it can cause more scleral inflammation and thinning later on and may lose the valve mechanism also. For the external incision, the size, shape, location, depth of incision all contribute to a good scleral tunnel. The size mainly depends on the hardness of the cataract, but longer the incision or it gets closer to the limbus, it can cause more astigmatism. So to negate that, there was a concept of astigmatically neutral tunnel explained by Koch. The arrows here point towards the incisionally neutral tunnel, where the incisions which are made in this funnel are astigmatically neutral or they create less astigmatism. So the incisions like Fron, Blumenthal or Chevron mostly lie in this funnel and they create least astigmatism as compared to the Smile and Straight. Sorry. Even the site of incision is important. A superior incision is more stable, but it can flatten the vertical meridian and cause more astigmatism as compared to the temporal one, which can neutralize the pre-existing astigmatism, which is common with old age. For creating an external incision, the first and foremost, a good hold should be there with your left hand instrument. The blade can be either a crescent knife or 11 number blade or a guarded knife for a beginner. The knife should be perpendicular to the sclera and should reach around half the scleral thickness. The previous was a Blumenthal incision, even the other one which I am showing here is a Fron incision. As you can see, it should go in single pass so as to create a clean, clear cut. Next is sclerocorneal tunnel making. This is the most important step. Once we get the first external incision, we should score the incision a bit if it's not correcting the up to the half scleral thickness. Then with a wiggling movement, we should go along the contour of the globe. That is, the scleral contour is different and the corneal contour is a little bit more steeper. So we have to follow that contour, go with a wiggling movement, and to identify the thickness, how much we have reached, we can get this show of the crescent knife. I mean, if it is too clearly seen, that means we are superficial. If it is correct plane, it will be translucently seen, and when it is deeper, the view of the crescent blade will be very less. Then we should be cutting inside out, and at the end we should make these scleral pockets, as you can see here. These pockets will allow nucleus to be accommodated during its extraction from the anterior chamber. But sometimes the things may not go well for a beginner every time. You can have buttonholing or flap cuts. Like here you can see the crescent blade is not at the correct plane, it is more superficial. And when the surgeon is trying to make the scleral pockets, he goes through and that's how the buttonholing has happened. These incisions will require suturing because otherwise they will keep on leaking later on and have more complications even intraoperatively. In another place, surgeon had this scleral flap cut as you saw over here. But then he was skilled enough, he went from the other side, got to the correct plane, and then he could negate this scleral flap cut so that it doesn't go through and through. So superficial tunnels can cause buttonholing, scleral tunnel deroofing, but the deeper ones can sometimes lead to uveal tissue trauma. We can have a premature entry which will cause leaking wounds, and there will be more risk of iris prolapse. The internal incision globe should be firm enough with a viscoelastic inside. The keratome should be quite sharp, and then we have to dip into the near the internal plane what we have made, and then dip into the anterior chamber. The knife should be parallel to the iris plane. These incisions are usually sutureless, but we will have to suture them if they are quite irregular or if those incisions are quite large. If we have any eventful surgery like iris prolapse or premature entry, if anterior vitrectomy was required, or there is a Descemet membrane detachment where gas is to be injected into the anterior chamber, or if the patient is one-eyed, also we should be suturing these tunnels. So the tunnel is the first stepping step of the good SICS. All the size, shape, site, everything is important for having a good, strong, stable tunnel. Assessing the correct depth is the first important step, followed by following the contour of the globe. The knife should be sharper and the correct dissection planes should be followed. Suture is to be done whenever necessary, and wet lab practices are the most important thing to go ahead with the actual surgery, because wet lab practice will give us a good assessment and control on our surgical steps. Thank you.
So thank you, Dr. Aditya. Dr. Aditya is a phaco-refractive surgeon from Amida Eye Care in Tiruvalla. He's also a phaco trainer for PG students in Amida Eye Care. Thanks a lot for your presentation.
Thank you.
Dr. Mohan Rajan, sir, can you come? Would you be able to come on stage? So we all know Dr. Mohan Rajan, and sir also will be giving a guest talk towards the end of this session. Please come, sir. So now we'll have Dr. Leena, who will be talking to us about anterior capsule related complications and challenges and how to overcome them.
Good morning all. At the outset, I would like to thank Dr. Ashish for giving me this great opportunity. I appreciate the efforts of the organizing committee in conducting such a wonderful conference. So I'll be talking about anterior capsule challenges. The main ones I'll be dealing with is a capsulotomy in an intumescent cataract. What do you do to prevent AF sign and when it occurs? What to do in case of a rhexis escape or tear, and also how to prevent difficult rhexis situations. Now, in an intumescent cataract, capsulotomy is a challenge. Why? Because we have a thin, fragile anterior capsule. There is too much intralenticular pressure. There is leaking of liquefied cortex, which makes a difficult view for the rexus. There is no red reflex, and the antechamber is shallow. So when you make a first nick on the intumescent cataract, as you all know, the milky cortex escapes and you cannot see the rexus margin. So what you can do is you can either aspirate with the cystitome that you have in hand, or you can use the viscoelastic gel to just clear out the cortex, liquefied cortex, and continue with your rexus. How do you manage intumescent cataract? You can do any of these methods. Coming to double rexus. So first you make a micro rexus with the help of your cystitome. Remember to pull towards the center, and the margin of the rexus does not extend to the periphery. So once the micro rexus is completed, you need to decompress the lens. You can use a Simcoe to aspirate out the cortex, the liquefied cortex, from the periphery towards the center. And once that is done, the lens is decompressed. Then you use soft shell technique. You flatten the capsule with viscoelastic. Use micro rexus scissors to enlarge the rexus. So when you cut, you should cut tangentially at the micro rexus. And once the cut is formed, you have a flap with which, and with a forceps, you enlarge the rexus to adequate size. When you decompress the lens, you should also remember to decompress the posterior cortex also. How do you do that? You can do it by different methods. You can tap the nucleus down. You can move the nucleus or rock the nucleus sideways so that the posterior cortex gets loosened and it comes anteriorly. You can twist or dial the nucleus, or you can even do a bimanual irrigation. Once that is done, you can continue with your double rexus. You can do a triple rexus if you think the rexus that you formed is small. That is, after IOL insertion, you can inject viscoelastic, make a small tangential cut on the rexus margin, and then enlarge it all around to an adequate size. Next is a snail track rexus. Here you make a small rexus, form the anterior chamber with viscoelastic, go around and enlarge circumferentially in small widths. The only thing you have to be careful in this is the flap of the rexus that you have cut will actually be elongated. Make sure it doesn't come out to the side port. You can actually cut it, shorten the flap, and then continue with your rexus and make it an adequate sized one. You can do a lens decompression where with a 25 gauge needle you go into the cataract, aspirate the cortex, liquefied cortex, and then once the intralenticular pressure is reduced, you can continue with your rexus. Now, an Argentina flag sign is formed when there is too much intralenticular pressure in an intumescent cataract, and this causes an uncontrolled radial tear of the capsulotomy. So once you have an AF sign, what do? You cut the rexus on either side of the AF flap and with a Vannas or micro rexus scissors, and then enlarge it with the help of a forceps. Make sure that the capsule is flat and you use viscoelastic. So once your rexus is done, this is how your rexus would look. Rexus tear, there are studies that say that a capsule tear, there's an incidence of about 0.79%. It can occur at any stage of your cataract surgery. The tear can be limited. It may reach up to the equator. The worst part is when it crosses over to the posterior capsule. So when there is a rexus escape, or when you see the rexus margin extending towards the periphery, you can do a Bryan-Little's maneuver. Here what you do is you unfold the capsule back and then you pull towards the center or away from the direction of the tear. Now this is another video where you can see that once the rexus is gone towards the periphery or is going towards the periphery, you just flatten the capsule, unfold the capsule, fold back the rexus flap, and then with the help of your rexus forceps, pull it towards the center or pull it in the opposite direction of the tear. Yeah. Now once the rexus has escaped to the periphery, you just use your forceps, try to bring it back by the Little's maneuver. You see that the capsule is not moving, stop it there, because you will be further extending the rexus tear towards the equator and beyond. So what you can do is you can use a rexus scissors, cut the flap of the capsule at the region of the tear, and then with the help of a forceps, just enlarge it to an adequate sized rexus. You cut with a rexus scissors or a Vannas, and then enlarge with the help of your forceps. Or what you can do is you can start off the rhexis from the opposite side and come and join to the tear where the rhexis has extended. These are the two methods how you can deal with the rhexis escape to the periphery. Now, how do you prevent this difficult rhexis situation? Every time you do a rhexis, make sure that the IOP is not high. There is no positive pressure. You can use pre-op hyperosmolar agents in case of an intumescent phacomorphic cataract. The speculum should not be too tight. You prevent eye movement. Make sure that the globe is well fixated. You have a very good red glow. Stain the capsule with tryptophan blue so that you have a better view of the capsule and there is reduced elasticity of the capsule. Keep the anterior chamber deep and well formed. Use highly viscous OVD. You can use the soft shell technique. Always keep the capsule flat over the anterior capsule when you're doing the rhexis. So remember that when you are doing your rhexis, always keep viscoelastic ready. You can keep viscot with you or a rhexis forceps and scissors ready because any time your rhexis can extend to the periphery. So to prevent, make sure the anterior chamber is well formed. You flatten the capsule, release intralenticular pressure in intumescent cataract, and once the rhexis has escaped to the periphery, it's better to use a side port because to the main port, the anterior chamber becomes shallow and the visco escapes. Flatten the capsule, unfold it, and pull centripetally. And if it does not come, cut and continue your rhexis. My acknowledgements, references. Thank you.
Thank you, Dr. Leena. Dr. Leena is an associate professor in Believers Medical College, and she's also a phaco trainer and a trainer for PGs and medical students in Believers Medical College. Thank you, Dr. Leena. Can we ask Dr. Philip Kuruvilla, just what is some useful tips that you would consider in these anterior capsular challenges?
I want to appreciate Dr. Leena for the wonderful videos of this thing. And for the beginners, I would suggest that you insist on injecting viscoat rather than a 2% methyl cellulose, because that will stay the material stays inside the anterior chamber much in a safer way. Number two, if you don't have viscoat and if you cannot afford, it's a cam case and so on, then what I do is, as we are doing the rhexis with a capsulotome, connect the capsulotome with the 2cc syringe with methyl cellulose, that is upper visc or something, and then keep injecting. Do you do that, Dr. Leena? Do you inject the visco into the chamber as you're doing the rhexis?
Actually, I don't, sir. I take it out. But then what you said is a better method, I think, so that you don't have to take out each time you do the rhexis and the antechamber is formed. I don't do it.
Yeah, it requires a little more dexterity and a little difficulty, because on the one hand, you're pushing the visco into the chamber. On the other hand, the tip should be absolutely steady so that you get a rhexis. So that is difficult, but I think it is a very good idea, particularly if you are doing the rhexis from the main wound. If you're doing from the side port, it is not so important maybe, but from the main wound, if you do, it's absolutely important. Yeah, but excellent videos and techniques.
Okay, we'll start the next topic. And I'll be talking about intraoperative hyphema and how you deal with corneal haze. Now, what I mean by corneal haze is not corneal ulcer with a huge scar in the center and those sort of things. That's better addressed by a cornea specialist. What we are dealing with is what cataract surgeons deal with, and that is the peripheral corneal degenerations and this sort of vague corneal stromal dystrophy. How do you tackle these things? You can see in the top right, that's how a normal cornea looks. And the center, you can see how this kind of just a disturbing sort of a peripheral haze. Now, these are, central view is there, but at the same time, you find that every step makes it a little bit tougher. So what are the small tips I can give you to, that we can all use to make this a little clearer? One is keep the eye totally wet. If you're going to do a peribulbar block for an MSICS, then the ocular surface will become dry. So make sure the surface is wet. Your assistant should be on her toes and make sure the corneal surface is wet. Next, use trypan blue as much as possible. So without trypan blue, you can also get away. But then after you do your rhexis, the rhexis margin becomes a little bit difficult to visualize. So For that reason, if you use stripe and blue, you'll have a clear, at least a margin where the rhexis is, and the rest of the procedure, especially in MSICS, where you need to make a decent size rhexis before you try to pull that thing out of the bag, you need to have a rhexis size. So here, this is like what Dr. Leena was talking about, an intumescent cataract where you need a decent size rhexis, especially with SICS. You don't want it to go to the periphery, you've decompressed, and multiple nicks I have made here, but I'm able to do so because I'm able to see the rhexis margin. The second thing is every microscope has got a retroillumination. Now, it is a good idea. Normally, we use both the retro and the direct illumination, but look how clear it is when you use only the retro. So pure retroillumination when you use, we will be able to visualize the rhexis a lot better. So in this case, without the pure retro, you are not able to see where the rhexis is. Here, the rhexis is very clear, and the IOL can be dialed properly into the bag. Otherwise, you really, if it is a rigid IOL, it's okay if it is in the sulcus, but ideally you want all the lenses to be perfectly inside the bag. Here you may miss and keep it in the angle also, in the anterior chamber angle. So retroillumination really helps in that case. Just another thing of retro, look how it is without the retroillumination. Looks like all the cortex has been aspirated there and looks like it is complete. But as soon as you sort of flush and then turn only the retro on, you can see the difference that it creates by purely turning off the main and putting on pure retro. You can see how much of cortex and other stuff and all is there inside the bag. And then you can go in, you can clearly visualize the rhexis margin, you can clearly go and remove all these things. So these are very simple things that we can do in all microscopes. And even if your microscope doesn't have a good retro, nowadays we have a separate attachment. One such is OmniGlow, which I think Aurolab is now dealing with. I don't have any financial interest, but that one is extremely good. You can connect it to any microscope, and so all of us have an opportunity to have very good retroillumination. So this is an NS5 case, but you can see here, even if it is NS5, very good retro, you can do the rhexis. Now, what other problems come with this peripheral corneal degeneration? This is one such case, everything is over, and so it's finished, and then you're just hydrating. The last step when you're hydrating, you can see those two bumps over there, and where the arrows are pointing, and when you're hydrating, have a look at what happens to that bump. It has gone and become a Descemet's detachment in that area. And so you must remember that these corneal degenerations, they are predisposed to Descemet's also. So always you should pay more respect, even when you're doing small steps like introducing instruments, exiting instruments, hydrating. You have to be very, very careful because you can easily end up with a Descemet's detachment. Even in the last step of the surgery, you can end up with a problem like this. So now that the Descemet's is covering the pupillary axis, you will have to correct that or rectify that. In this case, since it was a shallow Descemet's, I got away with just putting an air bubble into the AC, kept it tight for about 5 minutes, kept the eye nice and globe nice and tight with that air bubble, and that was sufficient enough to rectify this problem in this particular case. So in this case, again, the standard thing of using trip and blue, I have not done. So without trip and blue, what happens is you cannot see the rhexis margin, and just like what I said, rhexis margin was not clear. I had to make a slightly bigger margin, and that thing ran away to the periphery and caused some tear and extension to the posterior capsule. So I had to scoop the whole thing out into the angle in out of the bag. And now I'm extending that 2.8 temporal incision and doing some back cuts on both sides and making it into a scleral tunnel. Now, normally this procedure is quite safe and it is quite in a controlled fashion. All you need to do is put one central suture over the 2.8 temporal incision and you're good to go. And this incision is stable and does not cause much problem. That is in a normal cornea. When you have a severe degeneration like this, you should be careful. The apposition of the corneal lips or the valves is not as good as a normal healthy cornea. Somehow these corneas behave a little differently. So this kind of stunts really doesn't work well when you have a corneal degeneration. So this particular patient, internal lip, I'm just showing you here that it is a very nice healthy 2 millimeter internal lip. There's no problem with the incision at all. And normally speaking, I would just put one suture there at the main 2.8, that central area. But this particular case, I struggled a lot. So here it was actually an anterior capsular tear which had extended posteriorly. So a hydrophobic 3-piece IOL was placed into the sulcus. But the main problem was that after that there was a nice amount of leak over there. So normally this one incision would do and I'd make a suture there. But after one suture, two sutures, three sutures also, there was a significant amount of leak and it had a problem, then it ended up in hypertonic. So in these corneal degenerations, I think the better step would be, if you're doing phaco and you have to convert for any reason, maybe a different site superiorly, you can put one suture and do superior MSICS, and that would be more neat. Now, quickly going into this intraoperative hyphema, which is a common thing that you see much more in MSICS as compared to phaco. It is coming from the scleral bed. So basically, the standard thing is keep the eyeball firm, and just doing that itself usually makes the blood clot, and then within 2 to 3 minutes you're fine, and you can just not do anything else. But if your corneoscleral tunnel is not well constructed, then and the corneal lip is not good, then it will leak and go into the eye. So corneal lip has to be very good. And even after that, in this case, you can see the corneoscleral lip there is no problem in the internal incision either, but there is significant amount of bleeding. So I knew this was a major bleed. So I had to see what was going on. And one, retracting the conjunctiva, since I do a transconjunctival incision, retracting it, I was able to see what the problem was. There it is. It is a incision which has gone vertically backwards rather than parallel to the limbus. And that was what is causing that bleed over there. So somehow that has to be relieved, and the pressure inside the scleral pocket should be less than that of the outside, less than that of the eye. So once I make that nick over there on the side, you can see that the gushing of blood coming out to the external aspect, and now it is no longer going inside. So external lip, when you make it a very small incisions, external lip, this is one thing you will tend to have more of bleeding into the eye, and unless the eye is very well formed, you can have this challenge. The other thing is, when you have hyphema, sometimes it tracks behind the IOL and onto the posterior capsule. You must wash out all that. You can see there was absolutely no glow, but now you can see after washing out it becomes clear. So if you leave it like that also, it will get aspirated, but the next day the patient may have hand movements vision, and it will take a long time for that to clear. So it is very important, go ahead, go in front and behind the IOL and all that, remove every trace of blood that is there before you close the case. Normally what we see is, when there is a beginner or premature entry or whatever, those incisions you have to take sutures and close it up. Otherwise hypotony will be there. Even if on the table it is okay, next day the patient will have hyphema, and inevitably you'll have to take it up the next day. So that is suturing and making sure the eye is nice and taut and firm is very important at the end of the procedure. Thank you.
This hyphema can be a bad problem in MSICS. There are 2-3 precautions. One is, as Dr. Ashish said beautifully, keep it tight. The other thing is, keep the tunnel long if you think that there's going to be hyphema, if you expect it. Number 3 is, once it starts bleeding, one tip is that don't wash the area which bleeds. Let it clot. And to make the globe tight, to introduce water into the anterior chamber, use a side port or another part of the tunnel. But the bleeding area you should not touch, because if you touch that area, it will bleed more. So these are a couple of tips.
Very nice presentation, Ashish. Good morning, friends. I just want to add one point, because some microscopes, they may not have retro. So in those cases, what I would suggest is just use an endo illuminator. If you have an endo illuminator, access to an endo illuminator, just put the endo illuminator there, then you will be able to see that. Just like a retro, you'll be able to see that. Even in presence of corneal haze, the endo illuminator, I use the endo illuminator or you can use a chandelier also, and if you have access to it. But endo illuminator, I'm sure everybody can get that. It's not a very big issue.
We call upon Dr. Jacob Koshi, who is professor in the Department of Ophthalmology, Believers Church Medical College Hospital. He's a trainer to our PGs too. He'll be giving his 2 talks together, intraop small pupil and PC rent and vitreous prolapse. Over to you, sir.
Good morning, everyone. At the outset, I'd once again like to thank KSOS and Ashish for this opportunity. We've seen some fabulous surgeons. Now you can see some problems that we make, and I'll just try and show how I would handle some of these. So first I'll be dealing with intraoperative small pupil. Now, because we are talking about SICS, I'm not going to talk about the BHEX or any iris hooks and all, because those are difficult to use with SICS, especially as we are learning. And some of these small pupils may be intraoperative. Some of them you start with these small pupils, especially the bound down pupils in the uveitic cases. Always remember to, before you stretch it or do anything, please remember to just go under the pupillary margin and release all the synechiae. If you don't do that, the whole case becomes more difficult. So keep injecting viscoelastic, and it's not only at the pupillary margin, but you need to go all around. So you need to make 2 incisions and go all around. Once the synechiae is released, you can use these Y pushers, or you can use Kuglin hooks or whatever else you have in the theater. What I do is I make it at 3 different sites, and don't stretch it well beyond the limbus, like going very deep, because sometimes these can tear and cause massive bleeding in the eye. Just do a minimal stretch in 3 quadrants, and hopefully you're good to go. So this is another case that we see here, again a small pupil, and so I'm following the same technique that I said, where I first check to make sure that there is no synechiae. You put some viscoelastic. I've put a little bit of blue as well, and I go to stretch the pupil. So the 2 side ports should preferably be 180 degrees apart, so that you have better maneuverability. And I always make it in 3 different areas, and that gives me a fairly large size. And you can see here I'm doing an SICS case, and you can complete your rexes there. And most of the times these go pretty well. When you're prolapsing the nucleus, sometimes because of the stretch that you've created, the iris keeps coming in. Be careful when you're removing the nucleus. And again, during IA, you can easily catch the iris, you can catch capsules, so you need to be careful of what you're doing. Any lens can be put in if everything is going smoothly, whether you want to put in a PMMA or a foldable lens, and that should be fine. Now, here is another case where you have a small pupil, and you decide. So I try to put blue right in the beginning, because once you've put visco into the eye, then your staining is not very good. And I think that I should be able to manage it like the previous cases, where most of the time you do it pretty well. But sometimes when it rains, it pours, you start having problems, and then the problems keep compounding. And so here I think I'm okay. I think I'll start off with the rexes. Now, many of the times you have to do a blind rexes, where the tearing edge is just under the pupil. You can't see it clearly. And I think it's going well. And at somewhere around this stage, I realized that it has run off to the periphery. I'm trying to make some cuts to rescue it. Now iris has started coming out through the side port. I thought, okay, leave it. I'll just manage it. I thought I have a good tunnel, and you can see about 2 mm into clear cornea. But as soon as I start making the tunnel, some iris is sticking out, and I'm hoping it's just the floppy iris and nothing much. So I thought, okay, put some visco in just on top of the iris, push the iris down, and you should be good to go. So you inject visco there, and you should be good to continue. And suddenly the whole superior iris is coming out, and you realize you're in trouble. At this stage, I leave the iris alone. I don't manipulate too much. I'm going in with the vanas, and I'm hoping to make a nick to try and complete the rexes. So try and do these procedures without manipulating the iris too much. And so I managed to finish that. Now I've left with the difficult task of prolapsing the nucleus. Good hydrodissection is absolutely essential, and you can use the 2-hook technique, which is now very popular, to get 1 port up and then rotate the nucleus into the anterior chamber. So till here it is fine. Now all of you who've had iris prolapsing through a poorly constructed wound would know that this is the most difficult step, where you can have hydrodialysis, and you have to be extremely careful watching the iris which is prolapsing through the wound, being very careful, and just maybe sometimes just get the big edge out and leave it there, and then be careful not to cause a superior hydrodialysis. That's just going to compound the problems even more. Thankfully, this was not a very hard lens, and I was able to get the lens out. and then you reposit the iris. You can do that with any iris repositor and then gently start doing the IA. As soon as you start the IA, again you have iris prolapse. Leave it alone, don't keep handling it. Try and use the side port. And yeah, so here we have a PMMA lens going in. Thankfully, even though all the complications are coming, I did not have a vitreous prolapse or any rent or anything, and managed to put the lens into the bag. Remember to suture these wounds. You have to suture these wounds before you get out. Okay, so this is another patient now here. There's a little bit of subluxation pre-existent with some vitreous. Make a small rhexis. We've already heard how to do that, and after you make a small rhexis, you want to just extend the wound. Here you already have a little bit of vitreous there, and inferior about 4 or 5 clock hours of subluxation, and I'm just trying to see if I can salvage it and put in a lens. Now, getting the nucleus out is the trickiest part. If you can manage without extending your subluxation, then you're good. Always keep checking to see if the other areas are okay and the extent of subluxation. Now here I decide to put in a PMMA lens into the bag without a CTR, using the haptics to stretch the area of subluxation. And the technique I use here is what I have learned is I put a second instrument under the optic, especially if you want to put it in the sulcus, so that it helps you guide it better. If whenever you're putting a secondary IOL in the sulcus, in this case I'm putting it in the bag, but yeah, put in some pylo and make sure you've done an anterior vitrectomy. I've edited some of these things in the interest of time. Now here is another patient, fairly small pupil. So we think that we can manage these, and many of these things we are doing in a hurry because you might want to finish the list fast, and you do a blind rhexis, like I said, and things are going well. You prolapse one end out, start rotating. Sometimes getting this nucleus out of the PC into the AC itself is a challenge. You remember, use the two-hand technique. It makes things a little more easier. You can get the nucleus out, and everything is going well. And I start doing the IA through the side port, and many of these things are done blind, and then suddenly you pull out and you realize you've caught the capsule and you're pulling the capsule along, and then you just leave it there. Then your heart is in your mouth. You're wondering, have I pulled out too much? Should I have done that? Should I have not done that? Remember putting visco, trying to clear up, and you know that you have caused a zonular dialysis. Now, this patient had a foldable IOL, which is, anyway, I just pushed it back into the capsular bag. There was no vitreous, and the dialysis was maybe 2-3 clock hours. It wasn't causing much problem. Centration was good, so I left it there. And then sometimes you have these cases which, when you have the problem, you start wondering why you became a doctor, or why you took ophthalmology, and sometimes you start wondering why you were even born, those kind of things. And you're doing the case, and then half the nucleus has gone into the vitreous, and you have all kinds of things, and just trying to see what's happening there, and you see that the nucleus is floating in the mid-vitreous cavity, and you're desperate. Now, if the nucleus goes down, leave it, please send it to a VR surgeon. But here, I'm trying to handle it now. The block has worn off. Here, I'm planning to give a subtenon block to top up the block. Remember, if your block is not good, you cannot handle any of these things. Have a subtenon cannula, and it's a very easy procedure. Inframedially, just go under the tenons, go deep and inject, and that acts immediately. Good anterior vitrectomy is mandatory in these cases, and fortunately the vitreous was a little gel, and I did a little bit of vitrectomy, cleared it up, and could get it out. Triamcinolone is a must to make sure you're cleaning up adequately. For all the VR surgeons here, things may be very easy, but for us anterior segment surgeons, sometimes it's not. Once you've done a good vitrectomy, a dry aspiration, you keep putting viscoelastic and do a dry aspiration. Unless you're very sure, don't have fluid flowing into the eye. It will just go and hydrate the vitreous, and more vitreous will pop out. But you can do a dry aspiration, keep it in retroillumination, and try and see what's going on. At this point of time, I'm feeling a little more confident that I should be able to manage it as things are getting better. I keep removing the viscoelastic. Again, I put a little bit of tricot because I want to make sure whether I have brought out any more vitreous. Do a good anterior vitrectomy. Sometimes this tricot might go a little back, and on retro it will look a little white, and you might start wondering, oh, have I caused a detachment or anything, but generally they are okay. Remember to keep sweeping on top, and you can see a little bit of vitreous tag there, things like that, so that you know what to remove. Now, once you have done an adequate vitrectomy and you've cleaned up adequately, now here you're definitely planning to put the lens in the sulcus. Remember to inject the viscoelastic under the iris and above the anterior capsule. And again, just check all around if there is adequate support. Obviously, a PMMA lens would be better here, or a 3-piece lens. Don't put a single-piece foldable lens. And again, put it, be careful to go just under the iris, above the anterior capsule, injecting viscoelastic, and then you can dial it or push it in on whatever technique you're more comfortable with. Yeah, and you find that the lens is pretty stable there because there was good anterior capsular support. And remove. So these patients will have some visco coming back for the next few days, and so the pressures will be a little high. How much ever you clean in the anterior chamber, the pressures will remain high. Remember to manage the pressures well for the first few days. You can put in a bit of pilocarp in there if you want to make sure that to get the pupil down, as well as to make sure that you don't have any vitreous in the anterior chamber. Cleaning it up. Any patient you've done a vitrectomy, please remember to put in a suture. The last thing you want after all this is to try and go back because you have a leaky wound or a soft eye the first post-op day. So generally what I would do is I put a single cross suture for these cases. You can put a Fine's infinity suture if you know how to do that or you're comfortable with that. I usually put this cross suture. It hardly causes any astigmatism. It's just one single cross suture across the breadth of the wound. And you make sure that your wound is absolutely watertight. One thing that you will notice is the air bubble is pretty stable and it's not leaking out. That itself is a good sign that you know that the anterior chamber is good. The IOL is in position. Everything is fine, and yeah, you can close the case. And so you started off thinking, why was I born? Then you're thankful that you managed to finish the case by God's grace. And yeah, that's how I would try and manage an anterior case where the posterior capsule is ruptured with vitreous loss. Sometimes it's not always this smooth, and remember that if you can't manage it, just ask for help. That is more important than trying to be a hero in these situations. Thank you so much for your patient listening.
Really fantastic videos, and we all get into this kind of problems, and you managed it so very well. And thank you for being very frank with us, and because all of us feel that way in some stage or the other.
So next we have none other than Dr. Mohan Rajan, sir. I'm sure all of us know Dr. Mohan Rajan, and if I have to start the introduction, then it may take 10 minutes. And so we are almost short of time. Sir is a teacher of teachers and an excellent cataract surgeon. He's done more than 1.5 lakh cataract surgeries, as well as VR and a whole bunch of other things. So in short of time, because we're short of time, I'll straight away hand over to sir.
Thank you. Thank you very much. And good morning, ladies and gentlemen. Let me thank the KSOS for this wonderful opportunity. It's always a pleasure to come back to Kerala, and the love and affection and the warmth is something which is incredible. And I'm going to talk to you about the 3D, the decentered, dangling, and the dislocated IOLs. Okay, and yeah, you are able to see my presentation. These are my financial interests. So, how many of you have had this problem of late? Especially after the COVID, I find that there's a huge number of dislocated dangling IOLs. I don't know for what reason. We see this dangling IOLs, we see the decentered, we see this dislocated into the vitreous as well. So let's see how we manage this, different approaches. This is a 70-year-old male. I'll give you some case scenarios. Phaco-foldable 15 years back, 6/9 vision, and complaints of oscillopsia. Oscillopsia as if everything is moving, as if he has taken a couple of pegs of whiskey, okay, and history of blunt trauma and there are pseudo-exfoliation. You can see how it is moving around in the eye. So this is, though he had 6/9 vision, he was not very happy. You can see a lot of pseudo-phacodonosis. And it was a multi-piece lens which we implanted long time back. So the 3 pieces, when you have a 3-piece lens like this, then what we can do is we can go ahead and fix this 3-piece lens. This is called an ab interno technique. Okay, you don't have to enlarge the incision, you don't have to expand the IOL, you just go inside with small incisions. I create a 0-180 degree scleral flaps, which is a part of the glued IOL technique, and then I bring that lens up and make sure that you remove all the cortex and the capsular remnants, strip off the lens completely, because you don't want that capsule and the cortical remnants to come and occlude the sclerostomy site and where the lens is sitting, the haptic is sitting. Now, of course, you need to do a limited anterior vitrectomy to make sure that there is no vitreous coming in that area, and then catch the tip of the haptic. This is also the basic protocol or the thing which you need to follow in a glued IOL. Catch the tip of the haptic and bring it out, externalize it, and then go in and do the handshake technique, and don't catch the middle of the haptic. If you catch the middle of the haptic, it will break. Catch always the tips of a haptic, and all you can use micro forceps, which is available with Epsilon and many other companies as well, and then you create a Gabor-Scherrier tunnel. And once you put that haptic there, then make sure that there is no vitreous there in the anterior chamber as well. And many times we put tricot also and see. Sometimes there can be small fibrils. Put an air bubble, as Dr. Jacob Koshi was telling there, and then glue it. And glue that thing and put glue the scleral flaps, glue the conjunctival flap also. And you can see the post-operative result of this patient. You can see absolutely there is not even a micron of the movement of this. The entire lens is completely fixed. Patient is very happy. The oscillopsia is gone, and the patient's vision also improved to 6/5 in this patient. So again, another patient can see a decentered IOL. When you have a multi-piece lens like this, okay, if you are going to have a PCR, I'm going to put a multi-piece lens, don't leave it in the sulcus. If you leave it in the sulcus, and there can be a decentered. Okay, again this lens got decenters referred to us by another ophthalmologist. The same protocol, 0-180 degree flap, and bringing that lens up through small incisions and stripping that cortex and everything, and externalizing the tip of the haptic, and all with small 26 gauge needle we are doing this. So you can see another patient, you can see this is a 1 month post-op, 3 months post-op. This is again one of our postgraduates. She had a PCR and you put a lens, and probably the lens, if you put a lens in the sulcus like this, over a period of time that can be decentered, and what happens is you can also produce UGS syndrome. So this is in this case, because it's like this, vertically oriented, I put the 0-180 degree, I was sitting temporarily, and put a 0-180 degree vertically. So the versatility of this glued IOL is something which is phenomenal. You can see here, I bring that up all through small incisions, and many times you can use anterior chamber maintainer, or you can use, of course, the viscoelastics we do use very less in glued IOL, or you can use a pars plana infusion if you are comfortable with that area as well. So once you have a PCR, this is a posterior polar cataract. You can see the two typical lines on the posterior capsule. And you put a lens in the, obviously you cannot put a lens in the bag in this with such a huge PC defect. So you put a lens, haptic, the 3-piece lens into the sulcus. What you do is, don't leave it in the sulcus. If you leave it in the sulcus, they can be decentered and can have UGS syndrome as well. So you just lock that lens into the optic, into the bag, into the, into the capsular excess margin. The end point, see, if this is called the locking of the lens. If you have an optic capture of the lens, the end point is the ovalization of the anterior capsule. And this lens will not move a micron. You can see here 2 months, 9 months, 2 years, and the lens is also very stable, as if the lens is in the bag. And there's no decentration in the long term, there's no UGH syndrome. The patient's eyes are very, very quiet as well. So the patient is also very comfortable. Again, this is another patient, 63-year-old male, drop in the vision, 6 months duration, tennis ball injury. And usually the shuttlecock injuries are the worst. The tennis ball injury comes the next, and then we have the cricket ball and other things. So this is, you can see, this is a single piece lens. Okay, this is an SA60 lens which we implanted a long time back, and now it's got decentered. Obviously, you cannot glue this lens. If it's a multi-piece, we can glue it. We have externalized haptic, but a single piece lens, we cannot glue the lens. What we have to do is we need to put a suture. So we create an Hoffman's pocket and go from Hoffman's pocket is something which we don't open the conjunctiva at all. You go from the anterior, from the corneal side back, and you can see here this is the Hoffman's pocket which I am creating, and then I am creating a side port incision, and then going ahead and putting a suture. The 90 Prolene, or you can use that. One suture goes underneath the haptic, the other sutures goes over the haptic. So it loops the haptic. The suture actually loops the haptic and fixes the haptic to the sclera. So this is one of the methods by which you can fix a single piece lens which is there in the, which is decentered. Again, another patient can see here, this is a hydrophilic lens, something like a Rayner type. This hydrophilic lens, I tried to fix it up. Okay. The problem with this hydrophilic, I didn't even realize that. And this patient was also referred to me during the COVID time. I can see here, this patient had probably an injury and got dislocated. And what I'm trying to do is I'm trying to fix this lens with the Gore-Tex. You can see that I'm doing an anti-vitrectomy, and I'm trying to fix this lens with the Gore-Tex suture, and I'm putting a scleral groove there. But the problem with these hydrophilic lenses, they are very, very slippery. So don't attempt this, because in this case, see, it's very slippery. I was not able to even fix it up, and the whole lens started going south into the vitreous cavity. Immediately extended the incision and did what is called the anterior assisted levitation of the lens and brought it up, and then put a scleral fixation glued IOL. So quickly I will go through, because this is another patient. You can see here, this is a supraphobe lens. When the supraphobe lens came into the market, they didn't have an injector. So I used the Alcon injector. The message is, don't use one company injector to another for another lens. Suddenly it came into the jerk and produced a PCR. This is an young patient, traumatic cataract, and you can see here they opened up, and the PC opened up, the lens started going into the vitreous. Immediately what I did what is called the AL, anterior assisted levitation. So I go through the side port and bring that lens up, and this is a supraphobe lens. It does not have thick haptics like the Alcon SA60. So I just brought the lens up and then went ahead and then put this lens into the sulcus, and the patient is doing well. Again, these are lenses which are dislocated into the vitreous. For example, this patient had a dislocated lens into the vitreous, and you can see here the whole lens is gone in. In these cases, you cannot probably fish out the lenses. You need to go in and do this patient had a nucleus as well as a lens as well. You can see here a hydrophilic lens is dislocated, a part of the nucleus. So we are in double trouble. We need to remove the nucleus first, followed by the IOL, and then go ahead with the Exnic technique. Again, this patient we can see here, from the same eye, we had the 3 IOLs. Again, this is the patient, you can see SA60 lens which got dislocated. For some reason at all, I do not know, probably because of pseudo exfoliation or something which happened. You can see here this, I'm using a scleral flap, I'm using Gore-Tex suture. Problem is, over a period of time, this 90 Prolene and 10 Prolene can degrade, and that's why we started using Gore-Tex suture for fixing these lenses. So you can see here, I am trying to fix this lens and passing one suture, one end of the suture in front of the haptic, other one behind the haptic, okay? And you can fix that lens, entire lens. We don't have to explant these lenses. You can fix the entire lens without any problem at all. Again, another patient with a vitreous vitrectomy, nucleus bit removal, and then this patient we had to do a an XNIC technique. You can see this is an XNIC technique which has been popularized by the Aravind eye care system, and you can see here how beautifully it's been done without any problem. Only thing in the XNIC technique, you need to put a rigid multi-piece lens, and because you need to go through a 26 gauge needle, you need to have a scleral incision and go through that. You can see here pass a bent 26 gauge needle and loop that haptic into this thing without any problem at all. So only thing is the main protocol is 0-180 degree and making sure there is no vitreous in the anterior chamber. Again, another patient, you can see here, this is the patient. The video is not working, this one. Why? This video is not working.
I think we're running short of time.
No problem. Okay, thank you very much, KSOS, for this wonderful thing. Please email to me at drmohanrajan@gmail.com. I'll send you a color atlas of the retina and the optic nerve, which will be very useful for you. I am seeking your blessings and support for my AOS elections. Thank you very much. Wonderful opportunity and the patient attention as well.
I want to thank all the panelists and everybody involved in this IC. Thank you so much. And close.